kick off. Good morning, everyone. I'm John from HTN, and welcome to this webinar today, where we are set to discuss the question of, to support the NHS elective recovery, should every patient on a waiting list have a digital paperless record by 2028? So we're pleased to welcome a panel joining us to help us answer and discuss that question. So I'm pleased to welcome Andy Crathers, the Group Chief Technical Information Officer at University Hospitals of Leicester NHS Trust and University Hospitals Northamptonshire, and Simon McNair, Head of Business Development for Digital Services at Restore Information Management. So just a couple of things before we kick off. If you in the audience have any questions, please feel free to ask them via the chat. So we're keen to hear from you, any questions that you have, type them into there. And also, if you would like to answer any questions that I'm asking to our panel today as well, to let us know what's happening in your organisation, that would be great too. And finally, this session will be recorded. There will be a write-up done by the HTN team, so you can read or watch the session back at a later date and share it with your colleagues. So let's start with some wider introductions. If I could ask, Andy, could I come to you first in terms of your role, remit, organisation, and perhaps could you give a digital overview, an overview of your digital journey today?
Thanks, Ron. I hope you can hear some of these. I am the Group Technology Initiatives for a group of acute hospitals, so across 3 hospitals in Leicester, and we've got 2 in Northamptonshire as well, and we're working on across that kind of group of acute hospitals to see how we can start bringing our technology and systems together to best benefit our workforce and our patients. So our digital setup. So we are, from a Leicester perspective, we sit in the middle of the Leicestershire and Rutland ICS, and we've got a shared care record across that footprint, and we've also got a shared care record across the Northants footprint. We've got partially deployed EPRs at Leicester and Northamptonshire, and we've got a different EPR at Kettering. So we've got a bit challenging kind of how we get those systems to interoperate and work together for some of the things that we're going to be talking about today. So I think a bit of a mixed picture for us at the moment. Still lots of paper in use, but we're very much on a pathway to deliver digitisation, and we're seeing a lot of the work we're doing locally with the federated data platform products and other things, how that having data available to our colleagues benefits us and allows us to work differently. So yeah, a lot of work going on from a digital point of view, a lot of transformational work going on from a better use of data perspective, and that's really at the heart of our strategy. We've got a strategy called One Digital across Leicester and Northamptonshire, which we're looking to progress. So yeah, that's just a little bit of our context. John, thanks.
Fantastic. Thank you, Andy. And keen to go into a bit of that during the next hour. But to stay with introductions, Simon, can I come to you, please, to hear about your role, remit, and could you tell us a bit about Restore Information Management, please?
Yeah, sure. Nice to meet everybody. Yeah, Simon McNair. I head up Restore's business development function for the digital part of the business. So been in about 3 months. Primarily joined as the organisation is transitioning from what was a more recognised records management provider into a more integrated services provider of customer communications management, information management, and digital transformation services. Kind of background of about 25 years. Working with healthcare and public sector clients on some of their larger programs of transformation around how they manage information and how they transform the way they work, and particularly how they extract value out of data and operate more efficiently given some of the technologies and services that are available now. So yeah, really keen to join this panel, and thank you for the opportunity.
Fantastic. Thank you, Simon. Emily, could we have the next slide, please? So the session today is framed around the question of, to support the NHS elective recovery, should every patient on a waiting list have a digital paperless record by 2028? So we're keen to first start to hear from you in the audience. What is your view on that question? And we have a Slido on the screen. If you could answer it by either going to slido.com and typing in the pin that's on the screen, or scan the QR code, and it'll take you directly to a place to answer the question. So keen to hear your view. Should every patient on a waiting list have a digital patient record by 2028? Let us know what you think. All right, can we go to the next part? Emily, see answers coming in. Fantastic, thank you. So we'll start to hear your views in the audience, and then we will start to debate that and discuss that between the panel. Yes, even sooner if possible. Very interesting. A great ambition. So large consensus to say yes, completely, absolutely. It's a great objective. It's a good ambition. So we'll get into this question and hear what's happening in Andy's organisations and Simon from the organisations you are working with. It's an ambitious, but what is the BCP? Oh, I'm not sure what that acronym is.
I think it's business continuity planning. Yeah.
Oh, fantastic. Thank you. Needs to cater for those that don't want to be digital. Excellent point. Not sure why it's taken so long. Okay. And everyone should, but the NHS needs to be joined up in their services. So fantastic. Thank you for submitting your answers. And we'll move on to ask this question to our panel. So Andy, can I come to you first, please? So to support the NHS elective recovery, should every patient have a digital record on the waiting list, and where are you up to in your organisations in sort of tackling that?
Thanks, John. So yeah, I mean, I think my initial response to this question, or similar versions of this question, would always be yes, absolutely, we should. And I think someone just put in their response there, you know, we should be doing this sooner, really. I think there's a perception thing where I think lots of our patients already think we've done this, and we've spent a long time talking about frontline digitalisation and how we move away from paper, and how we make sure that we are now working in a way that is a 2025 way of working, not a 1995 way of working, which I think we all know still is going on in pockets around the NHS. I think for our organisation, as I alluded to earlier, we've still got a bit of a mixture of sort of historic ways of working, lots of variation in bits of process. We did a significant project earlier in the year to upgrade our core administration system across our Leicester hospitals, and that we'll be following that with the same piece of work in Northampton shortly. And that allows us to do things like have direct connectivity to the electronic referral system and take information coming into the organisation, effectively do digital triage of those referrals and manage them much more quickly into the right place in terms of, are they with the right service? Have they been triaged? Are they now on a waiting list more rapidly? Whereas, you know, more traditional ways of that would be to review a set of referrals that have come in, have to kind of sift through them, triage them. Maybe there's a spreadsheet involved where someone's trying to keep track of who's looked at what. So, you know, we're certainly, by improving the tooling that we offer to our clinicians and our administrative staff, able to improve some of the timeline and the efficiency of some of that process. And then I think really the outcome here is, and this goes for a lot of what we're trying to do with digitising our processes. It's not just about the fact that it's now digital rather than on paper. It's then that we've got the data, and what are the insights that we can generate from having not just some PDFs either. You know, this isn't just about taking a document and scanning it as it comes in and then having a digital workflow rather than a paper workflow. It's about having that information in a structured format that we can then run algorithms across, and increasingly now we're having conversations around how does AI help to do some of this kind of triage and filtering and prioritization activity? How can it help to learn based on previous patterns of activity? How can it reach more deeply into the structured records that we hold for the patient and check what complications they might have, what comorbidities, what other conditions? I think the shared care records and the ultimately now, as we're talking about moving towards a single patient record, having that cross provider and cross kind of geographical boundary view of a patient, again, I think is a thing that generally people outside the NHS assume that we can all do, and we can't at the moment. So, you know, that's back to the answer to the question, really. Should we have digital records? Yes, absolutely we should, because it means we are informing our clinicians better to make decisions. So I think some of the challenge we see by not, and I think there's another way of looking at this, which is to say, well, what if we don't? So we perpetuate the current state, which there's risks. I talked to some of our operational colleagues about this earlier in the week. We still have a danger of doing things like repeating diagnostic tests if we can't see what's been done elsewhere and we haven't got that sort of up-to-date real-time view of the patient's condition. We don't want to be repeating blood tests and repeating scans for patients just because we don't know it's been done or we can't trust the results. We can't see them. Particularly from an elective recovery perspective, how are we preparing our patients for that, for being involved in that process? How does the tech and having a digital record allow the patient to be more involved and see their own record and be able to comment on it and say, no, I know I had that scan last week, or I know I've had those blood tests. But that's not just for them to check our work, it's for them to contribute to their own record. And, we can do preoperative assessments digitally, so the focus through the work we're all doing collectively now around digital across the NHS, focusing on the NHS app, making that the entry point for our patients. How do we do digital consent effectively? How do we make sure that we don't bring patients in who aren't ready for their procedure? Again, that's optimizing our capacity and helping to reduce that backlog. So I think the role of digital in all of this is absolutely fundamental, but we've got to transform how we work. It's not enough just to digitize our current processes.
Fantastic. Thank you, Andy. And over the next 45 minutes, keen to go into things like prioritization with other digital programs and some of the challenges and where we're up to. But Simon, can I come to you? And same question. What's your perspective? What's your view?
Yeah, look, I think Andy made an interesting point there around expectations from patients. They're very used to consuming digital services now, and the NHS is catching up. I think in terms of how it has the systems, the infrastructures, the capabilities to be able to meet the needs of those patients, both in terms of communication and servicing. I think it's a journey, is the way I'd look at it at the moment. The answer is yes. To the question, obviously, as we saw on the Slido response, patients are needing to have digital services, access to their information quickly, the ability to book appointments, the ability to communicate with the hospital in much more integrated and digital ways. And if I look at the paperless by 2028 question, particularly around those that are on waiting lists, I think the answer has to be yes, but it's also about the size and scale of that program and the maturity of regions and individual trusts on that journey. And Andy touched on some of the work that's going on there. I think the legacy of paper working is still prevalent across the NHS to very greater and lesser degrees across trusts. And I think there was a Times article from a couple of years ago that talked about I think it was 1.2 billion pounds that was actually spent kind of storing and managing paper records. So there's still that foundational challenge there that needs to be addressed. And a lot of that, cost and inefficiency is tied up in either that legacy way of working or what is often still a hybrid way of working. It's not a fully digital service. It might be a digital front door, but there's still some manual processes behind. And obviously the focus is moving from analog to digital as part of the 10-year plan. And as obviously supplier, we're starting to help support that and have been for a long time around both secondary care and also primary care digitisation programmes for the NHS. So.
Fantastic. Thank you, Simon. Andy, can we just dig into Leicester and Northamptonshire? So in terms of digitising, what percentage of forms are digital or paper-based? Where are you in your journey? And what have been some of the challenges along the way in approaching the digitisation piece? And are there any key learnings that you can take that you can share from that journey?
Absolutely. So yeah, so as I said, I think I alluded to this earlier, we're kind of very much in progress with our kind of digitisation efforts. So across our inpatient areas in Leicester, we've got majority of our kind of nursing assessments and those kind of pieces of documentation on the ward are digital. We've got electronic prescribing. We've got lots of our kind of handover information is all digitised, but we've still got people writing in the notes on the ward, and that's our immediate term challenge, is to move that onto our EPR platform. We've got an incremental approach to our electronic patient record. So we're working with our EPR supplier to sort of develop that product and make sure that it's fit for purpose for all of our areas as we sort of start to take the paper out. But in the next 6 to 12 months, we'll have been removing that paper from our wards and have all the medical documentation and all the nursing documentation in digital format. So that's a really exciting step actually for us. We've spent a lot of time putting the foundations in place. So in terms of the challenges, I think it's about not just rushing ahead and digitising as fast as possible. It's about making sure that you're joining the dots, and actually the thing that you deploy to clinical teams is greater than the sum of its parts. And if we do it right, we should always have the right workflow in the right place, rather than just having electronic copies of forms that we've been using for the last 20 years on paper. I think the other big challenge with that piece of work is around the standardization opportunity. So it's quite, the path of least resistance here is to everybody gets their own voice and everybody wants their own form and their own version of a piece of documentation. And actually that would create more complexity for us from a digital perspective, and would massively reduce the opportunity around benefits in terms of more structured data, better sharing across different teams and services. So probably one of our big challenges is how do we agree? How do we get our clinical teams around the table? And it's not an IT or a digital decision to make. It's around how does the organisation want to transform and standardise on those documents. And we're trying to do that at group scale. So we're trying to say, let's not have a different general surgery form in Leicester to the one we've got in Northampton. And we're also increasingly now saying, actually across the East Midlands, we're all working towards similar goals. We're all in a similar position. Why would all the acute providers across the East Midlands region need a slightly different form creating? Let's try and do as much standardisation as possible. So we've got a whole piece of work around nursing documentation across the East Midlands happening to standardise and agree what should be those documents, what should they look like, how should they be structured, to try and achieve that across the region. And that for us has massive benefits, because it means when you rotate staff and people move around, we've got staff that live between different hospitals and might do some shifts at one end or the other. It means they're not having to relearn how to use systems and processes, ultimately, hopefully in future, when they do shifts in different locations. We have with the big teaching hospitals in the region, we've got junior doctors that rotate between different sites. And again, if we can reduce the training burden and the retraining burden on them, that can only be a benefit as well. So I think there's lots of opportunities to share. Patients can be moved between different sites. If we're all working in a similar way on a similar platform or the same platform, it's much easier to share records and understand the context. And often the challenge with looking at somebody else's documentation, whether that's written or on paper, is understanding what they meant and what the context was of it being created. And if you start from a standardised position, that's a lot easier. And we're not great in the NHS generally at agreeing what those standards at that level of detail should be. So I think, we're I'd say partially complete. The exact percentage is probably less than 50% at the moment of all of our documentation, but that will massively accelerate now in the next few months from a Leicester and a Northampton perspective. The challenges would be actually scale of the work, agreeing the standardization, and that's ultimately a clinical standardization conversation as much as it is a digital one. And at what scale should we do that? And we're trying to achieve that at a broader scale across the East Midlands geography, not just for, across one or two of our hospital sites.
Very interesting. Thanks, Andy. We've had a question or comment come in. So keen to hear your view on this, Andy. So there's the digital skills ability of patients can differ. Organizations who have studied and produced personas show that there is a mixed ability of patients, but they will require different digital support and obviously community engagement to understand the capabilities of those different personas. How are we building that into the creation of some of these forms and standardization so it meets the varying needs of different groups of people?
Yeah, so I can certainly talk about some of the things that we're doing. So we are in Leicestershire, we've got one of the most diverse populations in the country to work with. So it's really important for us in terms of serving our populations across Leicester and Northamptonshire that we've got patient voices in the room. We're not making assumptions about not just about the technology either, but how people want to be communicated with and how easy it is for them to engage with us as big organisations. So we've got a number of patient reference groups set up, and we've got a patient-facing technology work stream that our teams are kind of coming together on. So anything that we do, whether it's looking at how we communicate appointment dates and reminders, what we're doing around the NHS app and how our electronic patient record gets connected into the NHS app to send reminders and set expectations for patients when they're on an elective waiting list for a procedure. It can be really difficult to understand what's going to happen next and where am I expected to be as a patient and when. And we sort of almost assume that sending a letter in English in the post is going to explain everything to the patient, and if we stick a leaflet in with it, well, that's as much as we can do, and we know that's not as much as we can do. So we've had some really interesting conversations with some of our local community groups around how to better interact with them, and some of the feedback we get is that a lot of those groups would rather be communicated with in voice notes, for example, so where maybe there's a varied degree of literacy, or actually paper letters in 2025 aren't things that people are used to receiving now. None of us write letters to each other and put them in the Royal Mail, do we? So, but we still do that from a hospital perspective often. So I think listening to those community groups and saying, well, how best do we get the message to you so that you're more likely to be able to arrive for your appointment on the right place at the right time, and you're more likely to arrive prepared and have done the things that maybe the service that you're being treated by needs you to have done. We've got to have the patient voices and the communities engage with that. So we've been using we've got a number of patient reference groups in place. We're sort of increasing now using those as our forum to have that direct conversation. So this is about involving patients in how we might design solutions and ways of working in future. Because if they're not in the room, we need that co-design, that co-production to make that effective. I think there's also a point about, we know from a digital exclusion perspective that is a challenge for some of our patient groups, and we can't assume that one size fits all. So for every number of patients that are much more comfortable receiving their appointment reminders in a digital way or receiving their group assessment questionnaire on an app to fill in, there will be a group that aren't and can't. So how do we engage with the community groups to talk through that? How do we make sure we've got those exception processes in place so that we're not excluding patients from being able to be treated by our services? So I think whatever we do, we've got to bear that in mind. And it's often the case that as long as you've got that in hand when you think about designing a new way of working, you can free up a bit of capacity to make sure that it's a bit like doing a self-check-in on a clinic. You can, by having the patients that can check in themselves, you're freeing up the person who's on the reception desk to help the people who need help. So I think we've got a responsibility collectively, whether it's in digital or our operational clinical colleagues, to make sure we've got the patient in the middle of our thinking on this. And for us, it's about how we engage with the community groups, make sure we're listening, and that we design those processes and services.
Thanks, Andy. I think you just broke up slightly there. I might have lost you. Yeah.
I can still hear you.
Oh, right. You might be back now. Might have a technical issue there, but it's breaking up. So I'll come to you, Simon. So thanks for that, Andy, and Salim. Thanks for the question and bringing this into the conversation, actually, this topic into the conversation. Simon, what's your perspective?
Yeah, I mean, I was just going to build on that, actually. I had historically I've had a background in customer communication management, and I think the principles of this are around communicating with customers, or in this case, patients, on the channel of choice. So how you may want to receive your information, John, from the local hospital may be paper-based, but with a follow-up on text or SMS. Others may purely communicate on email, and you've got obviously a very mixed demographic there. So I think the point I was going to make there is very much around communicating and understanding the preference choice of the customers, in this case the patients. And then it's also about providing the technology and the tooling to communicate effectively. So an example of that, Restore does a lot with the NHS around managing that flow of communication, particularly in SMS, in email, maybe multiple formats, and also have capability to support with some of the accessibility. So how do you address the needs of those that have requirements maybe for Braille or large format within the way that you communicate? And that technology is available to personalize and tailor some of the communication, both in the format and with the accessibility requirements that are needed for some of those patients. So as long as you understand the preference and you understand the requirements, you can kind of design and build and operate a communication platform and a way of doing that. And again, that's an example of where Restore's helping that communication process with patients to improve some of the patient outcomes and patient care. So
great. Thanks, Simon. And we look to have you back, Andy. Hopefully we do. Can we move on to, so we've spoken about longer term challenges, and we've spoken, well, the longer term vision, and we've spoken about short term challenges. Part of the question at the start was by 2028. So I just want to pick up on that. Is 2028 achievable? And what's your view on that? How do you balance prioritization with other digital programs? And is 2028 a time frame that is achievable? Andy, could I start with you for that one, if we have you?
Yeah, so hopefully you can hear me again, John. Is that working now?
Yeah, that's good. Thanks.
Great. So, yeah, sorry, so network problems always helpful, aren't they, on these things? So yeah, I mean, I think from our organisation's perspective, we are on a trajectory to deliver this imminently. So I wouldn't worry too much that we wouldn't be able to say by 2028 we've got a digital record and we're receiving referrals into our organisation from primary care. So people who've been to their GP and had their decision to refer for an elective procedure and be put onto the waiting list, that process for us will absolutely be digital by then. So I don't worry about that. I think the bit that I worry about is what I referenced earlier, which is the getting everything in one place so that we're not still kind of scratching around for bits of information about a patient. So we increasingly now are we're a big tertiary centre in Leicester, for example, and we get patients arriving to us from all, a much wider geography than just people that live in the Leicestershire area. So it's those patients that maybe end up with the repeated questions and can you just tell me about your medical history, and we have a responsibility, I think, by 2028 to have reduced some more of that duplication of questioning and visibility of the wider record. So I think there's multiple ways we can start to try and solve that. Sort of interconnectivity between different EPRs and some of the work that the NHSE architecture teams are doing now around how we need to be able to interoperate between systems. We've had a lot of time and money spent on digitising and putting electronic patient record systems into acute hospitals. We now need to start using those effectively. So as I said earlier on, that's partly about the data, which I'll talk about in a second, but also it's then making sure that those systems are able to share information across. So we've got shared care records in place. What's the connectivity and what's the standards and what are the approaches that we need to make sure that if a patient needs to move from one geography to another, that we don't lose access to all of their digital records. If we could spend a lot of time digitizing something that's very local and very kind of geographically fixed, and that often doesn't benefit the patient because they may need to be treated in a different place. So I think that's probably the bit that I think is going to be more challenging. We've got the right set of conversations going on around interoperability, around how do we start to move in the direction of a single patient record for the patient across the NHS. Those are the right things to be doing. Whether we get funding and whether we get the right people and the right vendors and the right kind of governance around that to make it happen is, I think, our challenge collectively. And I think there's something around how we collaborate on this. There's one of the things that when we speak to people outside of the NHS or outside of England, you know, the level to which we've still got lots of organisational sovereignty in the middle and organisational boundaries and decision making that can, at least on these kinds of opportunities, slow us down. So how do we get the right steer nationally and regionally on this and make sure that we're not kind of stuck because there are some providers that are further ahead than others, and that might be a digital maturity thing, or it might be a kind of local decision making thing. So I think there's a few obstacles that we need to overcome to have achieved that sort of 2028 objective. I think the point I was just going to make around the data is, even very locally, we see the benefit of sharing information better. So across our two hospitals in Northamptonshire, Kettering and Northampton, we've in the last 12 months got in place now a single waiting list for our services, whereas previously we had site-based waiting lists. And just some of them, it sounds really basic when you describe it, but the ability to see where the capacity is and manage those patients across the two sites rather than just individually, that's made a huge difference to the patients, the speed at which we've been able to treat patients. We've transferred, I think, around 1,200 or 1,300 patients now from one waiting list to another across the two sites in both directions. And that's reduced our waiting times across both hospitals. And we've got examples where patients are seen on average 41 days faster. So they're getting their treatment quicker because we're able to better use capacity across a bigger geography. So if you take some of that and extrapolate it, and it won't always be able to, because clearly there's a limit as to how far around we can move people across the NHS, but there are some solutions to our backlog challenge in the better use of data and the more kind of intelligent use of the capacity that we've got in the NHS.
Very interesting. Thank you, Andy. And Simon, your perspective on 2028 and organisations you work with, is that achievable? What's the best way to approach that aim? You're on mute, Simon.
Of course I am, sorry. So yeah, I mean, coming from the perspective of from a records management and a physical paper record, if you're going paperless, there is this legacy challenge which I touched on earlier. I think short term, assessing where organizations are in terms of that digital maturity, a lot of the paper to digital, the digitization, is predicated on further investments in infrastructure and systems at a trust level, or increasingly at a regional level, and an ICB, or across a number of trusts within a region, that actually are much bigger levels of investment. Change programs requires resources both across the trust and suppliers to effectively deliver those. So I think short term, there are some quick wins about, simple things like how do you reduce your costs of storing paper? We touched on earlier, 1.2 billion over a 5-6 year period. There is a quick win there for the NHS in terms of storing and managing that more effectively, more cost effectively, one that repurposes the space that's critical and in demand on hospital trusts' own real estate. I think there's a piece there around information governance. Is there an opportunity to have a clean set of metadata and inventory that the trusts keep, i.e., is there some opportunity to destroy some of those inventories where they're no longer needed and they've met compliance, appreciating there's a number of either embargoes or investigations and activity that means trusts may not be able to, but where's that happy balance between risk and disposition of those records? And then obviously those larger digitization programs, whether they're done in bulk, which we certainly see across the NHS, or whether that's done on demand. And I'll kind of touch on that later. There are a couple of models and options that work effectively. So I think there's some kind of quick wins in some of those more legacy areas. And then I think, to Andy's point, there is a much bigger challenge around the infrastructure, the systems, the interoperability, particularly as that starts to either be set as a national program. We've seen, federated data platform and that program deployed nationally and used and utilized by the trusts, or whether that's more across regions or hospitals within a particular ICS, integrated care system, or integrated care board. So that's a much bigger challenge. Funding pots need to be a lot more significant. And I think the longer term challenge there is always going to be balancing the priorities of clinical care and reducing waiting lists with some of these larger, more costly change programs, which they're not done quickly. They are 2, 3, 4 year programs in some cases. So I think the balancing act is the challenge. But I think certainly the key for me is around every patient on a waiting list, because by definition you're able to prioritize where you invest some of that digital funding around those that have the demand, and therefore at the front end of that process digitize on demand those that are on the waiting lists. There will be patient records and information that is not as much of a priority. So it's about intelligent use of funds to be able to help digitize and go paperless by 2028.
Great, thanks, Simon. We've had a question come in. The first is from Sean, and it's a great aspiration, but there's a risk of a two-tier health service. And I know a few trusts are pausing the development of their digital portfolio for at least 5 years. How does the panel feel about that? Interesting point. Andy, do you want to go first on that one?
I think it's linked to what Simon's just said about balance. So there's a level of ambition, I think, which organisations will have, but there's also a set of challenges that everybody's got around constraints on workforce and pressure to reduce headcount, and also to make savings every year. That's the world we operate in from an NHS perspective. So how we then position digital and digital records and our ability to influence the elective recovery within that context, I think is variable, and I think that's what Sean's question is really about. If some organisations are saying, well, given how much pressure we've got on budgets, we can't fund this piece of work, it would be interesting for those organisations that have made that choice, whether there was a proper benefits options appraisal done there, because for me, digital is one of the only routes we've got out of the challenging context that we're in. So there's not that many transformational levers we've got to pull in our organisations to work differently and change how we deliver care, to be more efficient and to do more with less. And if we're reducing headcount and we're reducing budgets and we're still operating on paper, it's really challenging, I think, to say that we're going to be successful in what we're trying to achieve in terms of delivering better care to patients. So I think we know that's the challenging environment we work in. I think it's interesting around the two-tier comment, because that's kind of linked to what I said earlier. There is local decision making here. There are local balance of priority decisions that every trust board will be grappling with. Should we spend more on the estate and fix the leaking roof? Should we be spending more on digital and digitising our records? Should we be replacing the broken medical equipment? Every organisation's challenged with that from a capital investment perspective every year. And should we be putting more people into our digital teams at a time when we're being asked to reduce costs of staffing across frontline services? I think you can do a bit of both, because actually if you resource your programs correctly and you get the right balance of work happening, the digital delivery should allow you to operate with slightly less staff. Particularly in our case, we look at a lot of the kind of administrative workforce and say, how could we better be using those people to improve our productivity and see more patients, rather than just cutting numbers and saying, well, now everything's going to take longer because we've got less people to process the paper and to run the sort of the legacy and historic processes. So I think if we get the balance right, which is back to what Simon was saying, digital is one of the only options we've got to try and progress whilst we're in these really constrained times, but it's not easy. And we're also within digital then balancing our priorities, linked to your previous question, over, are we investing enough in cybersecurity? Are we investing enough in making sure that the foundations are in place? Have all of our clinicians got the right equipment? Does their laptop start quickly enough? Have they got an iPad on the ward when they need it? If we don't have those bits in place, then working on entirely digital records is impossible. So I think that's our challenge as digital leads, is to make sure that wherever we can, we're getting the balance right, and we're doing enough of the transformation work, and we're looking at automation opportunities, and we're seeing where we can streamline processes to free up that time for our clinical teams, and ultimately help take some of that pressure off. But the nature of it is it's really challenging. So the balance is important. I think if organisations take a decision to say we're going to stop all of our digital programs, that's a real challenge, I think, unless you're really digitally mature. And we know from the digital maturity assessments that there are very few organisations at the moment in the NHS that can really say that.
Excellent points. Thanks, Andy. One question that I'd like to ask is, how do we measure success? And we've spoken about, and you've mentioned efficiency, time savings, but are there some metrics that would make more impact, like the business operational impacts of reducing DNAs by 5% or something, opposed to the balance of increasing qualities? It's like, actually, what is the measure of success? Simon, what's your view on that?
Yeah, I think so. If I think about some of the business value that gets delivered through a lot of the programs that we're looking at here, it's certainly, and as a supplier into the NHS, we are very focused on how we deliver cost savings for the NHS, for all the reasons that were touched on earlier around, challenges around funding, workforce prioritization, business cases that deliver effective returns on investment are critical both in the short and the long term. So I think that is a key priority that we focus on working with the NHS. I think the other area is around service improvement. The foundation that working in either entirely paper or even a hybrid environment means you have inefficiency. And if you are working with paper, that ability to automate and share data and use that data more effectively across the organisation is limited. So I think it's about service improvement levels, and ultimately about better outcomes. The transition from analog to digital is all about making sure that the patient data is available, giving patient choice and information access to that data, where the patient is in control of it. That's obviously the kind of the primary aim of this, but it's ultimately about giving information to clinicians in the format they need it, when they need it, to make effective decisions and improve patient care. So those are the kind of key requirements we focus on: efficiency, cost saving, but ultimately how do you improve the service, and how do you do that in a secure and effective way, given these are large scale change programs.
Thanks, Simon. Andy, is there anything you would like to add to that before we move on?
Yeah, I think I'd just probably add a comment that our success metrics, naturally, because we're spending money, there's a financial element to that. So we talk about return on investment with our board and say, if we spend this money on digital, where can I take costs out? So some of what Simon was saying earlier on about paper storage costs, and also like transport of paper as well. You can store paper notes off site and free up the space, but you've then got to pay for them to be transported back. So we're doing some work at the minute to remove that in the next few months, because that is a cost that's in our gift to reduce. So there's an efficiency and a kind of cost element to it. But fundamentally, if we're not improving our patient experience and we're not improving our staff experience of working in the organisations, then I don't think we're doing what we need to be doing as digital functions. So, you know, I think as we measure our progress, we've got to do some experience-led metrics and be thinking about it from, again, put the patient back in the middle of it. Is it better? Is it a better experience being treated by organisations as we progress with our digital journey, which is linked to what we said earlier about digital inclusion? I think we've got to keep checking that and make sure that we're not just measuring success on pieces of paper removed or you know, amounts of money saved and redistributed elsewhere, because fundamentally we want our organisations to be positive places to work, and we also want our patients to have the best possible experience when they come through the door.
Great points. Thanks, Andy. The next question we've had is, interested to hear from the panel what you are most excited about in terms of opportunities that this will unlock, in terms of opportunities that this will unlock in the future. Interesting question. Simon, would you like to take that one first?
Yeah, I think Andy's touched on it a couple of times. I think it's about the data, and it's about improving the customer or the patient experience. I think at its heart, I think we all you know, we support the NHS in the ways that we do to ensure that they're efficient, they're effective, but ultimately this is about improving outcomes. And I think we haven't yet fully harnessed the value of the data. And I know this is a bit of a challenge, because ultimately we're talking about patient data, we're talking about medical information, but I think there's a huge opportunity, given the pace with which technology is developing, that if you can unencumber yourself from some of the legacy systems, the processes, the paper, and the legacy infrastructure, so you have more standardization, more interoperability, more effectiveness. The bit that excites me most is actually what can be done with the data in an ethical way, in an effective way, using the technology to improve some of the outcomes. So there's a layer and a stage on from what's being delivered today, that when you have the right infrastructure, the right systems that talk to each other, and you understand the data, being able to extract the value and drive positive outcomes out of the data is probably what excites me most.
Great, thanks, Simon. And Andy, same question to you.
Risk of just saying the same thing in a slightly different way. I think absolutely it's about the data. I think with the pace of change at the moment around, we use AI a lot. We get lots of opportunities thrown at us around AI is going to solve everything, AI is going to change the world. I think in healthcare, we've got to get, as we've been saying on this call already, we've got to get those foundations in place, otherwise we can't take advantage of any of those opportunities. But it is fundamentally about connecting data together in ways that we've never been able to do before, because it's been locked in paper folders on wards and in basements and in storage units. And I think for me, it's about how we can connect not just the clinical data. We talk a lot about clinical records and making sure that's all digital and shareable and available and the patient can contribute. That's all important. But the connectivity between clinical, operational and research data, our ability to start predicting what's going to happen to a patient when they come through the door from an acute hospital perspective, but more generally from a population health perspective, how do we manage our limited NHS resources better across all the different care settings? You know, how are we risk stratifying our patients correctly in primary care based on information we have maybe locked in mental health, community, acute and primary care records, and what does the social care side of things add? You know, we've done some work in Leicester and Northamptonshire around making sure that social care are part of that shared care record conversation, and that adds real value in terms of having a whole picture of the individual, not just the kind of their healthcare history. And what is our opportunity around working with our academic institutions and third parties and interested kind of industry partners to make use of those bits of information, because there's a very operational thing here about triangulating how many staff we've got on shift at the time, how many patients we've got coming through the door. Are we optimizing our use of people and resources within the hospital? There's loads of examples of that once you get the data in one place and you can start to use some of the AI tools across it. But I think from a clinical perspective, I talk to my clinical colleagues, there's lots of opportunities for us to do things, some really interesting things with sort of mining the data that we hold, or increasingly now we're starting to hold that's no longer locked in paper records. So that's the bit, how do we predict? How do we start to address those inequalities? How can we support action earlier? And ultimately make better use of the resources we've got. Demand is going to continue to increase on healthcare. We know that. Are we seeing people in the right place? Are we reducing effort and diagnostics and all of those things? And how does the data help us with that? And so I think that's the bit that's exciting, given the tooling we now have and the opportunities we have to use large language models and AI, Gen AI capability. There's lots of buzzwords around it, but it is really exciting once you get into some of the real tangible use cases.
Yeah, definitely. It is quite exciting, really, because we can realise prevention, moving from reactive to proactive. Yeah, completely agree. We've got a bit of time for some questions. If anybody in the audience has a question, type them into the chat. We've got 8 minutes or so. So first question that's come in is, does the panel feel it is time for the Chief Patient Officer to be a key stakeholder and on the digital patient journey, who the board and digital leaders can look to for supporting digital strategies and programs? Great point, Salim. Andy, what's your perspective on that?
So I think I said earlier, right, putting the patient at the centre of what we're doing is absolutely critical. I think the challenge, and we see this actually with our clinical digital leadership, the challenge is to have a representative voice. So we've got real diversity of population, of needs, of digital confidence and digital maturity in our patient groups. So it's absolutely the case that we need patient representation in the work that we do. Is it the right thing to have one person at the head of it? I think we can debate whether that's the right way of doing it. I think the challenge is, it's a bit like appointing a chief medical information officer or chief clinical information officer. They start to become immediately part of the digital team, and there's real strength in that. And they're part of those roles that we've had in the NHS now for a number of years, is to act as the bridge between clinical and operational services and the digital team, understand the art of the possible and do that kind of translation of what's possible, what's feasible into what's needed with that professional background. I think part of the challenge after a while is, how do you still make sure that that's grounded in what it's like to be on the front line? And my colleagues at Leicester and Northampton still make sure they spend time on the front line so that they're working with the day-to-day colleagues and getting that perspective. I think the challenge with having one person who's your chief patient officer would be that, they're inside the tent, which is a great thing. How do they still maintain that perspective for all of the different community groups, if that's the case? So it might be a great thing to test and see whether having a patient representative, almost like as an employee sitting on those groups, I think that person would have quite a challenging job to be representative of all the groups. And we need to think about, that's the thing we're talking about at the moment. How do we make sure we've got the right people in the room, and that we are representing those people? But I think fundamentally, conceptually, it's a great idea. It's then how you make it work, really. And is that too much for one person? It's probably the challenge.
Thanks, Andy. Simon, is there anything that you would like to add to
that? Yeah, look, it's a really difficult one. I think there's such a diverse set of communities that the NHS represents, but I definitely take the point that how do you work within but represent the customer base, or in this case the patient base, and do that equitably and fairly. It kind of links back to the point earlier, I think, as well, around accessibility and patient choice and very diverse populations that the NHS Trust serves. So I think it's an interesting point. I wonder if it can be better served by other ways of getting that feedback and engaging with the communities with which the NHS Trust serves, rather than a figurehead within the organisation. But that would be my personal view.
Thanks, Simon. Okay, so it doesn't look like we have any questions. So could I ask one more for a key takeaway? So if there's one thing or two that you'd like the audience to go away with from the discussion today, what would that be? And we'll use that to wrap up the session. So Simon, could you go first? What's your key takeaway from today?
There's a lot going on. It seems like a simple statement going, paperless by 2028 for everybody on a patient waiting list. We know they're very significant. So I think the takeaway for me is, be really clear around those quick wins, because they are out there. And then the longer term transformation of how the NHS services its patients and the infrastructures and the systems, that is a much longer, bigger commitment that needs the long-term funding, the resources internally, and also the resources from the supplier community to make these things happen. The EPR vendors, the digital transformation providers, making sure everybody's on the same page to be able to deliver that, and ultimately keep the patient at the heart of that decision making and that journey. So those are the key takeaways for me.
Super. Thank you, Simon. And Andy, what are your key takeaways?
I'd say, I think, to summarise some of the things we've been saying, I think there's something for us collectively across the NHS around how we're collaborating across organisational boundaries to do the right thing. And when I say do the right thing, keep the patient experience at the centre of what we're doing. And that is challenging because of the way we're set up and the way money flows and the way we're all at slightly different starting points. But I think the more we talk to each other and work together on it, the more we can knock some of those barriers down. So that's, for me, a really important step. I think fundamentally we're still balancing our investment, what limited investment we've got in the operating context that we talked about earlier, over getting the foundations right, making sure the interoperability standards are happening, getting rid of the paper and digitising, and we've got to do all of that. And then we've also got to start taking advantage of the exciting opportunities around data and the AI ideas that we were just referencing at the end there. So I think that's our challenge, is how do we balance all of that whilst keeping the patient in the middle. And I think making sure that we're, having said all of that, the more we digitise, and someone referenced it in one of the questions, I think, what's the business continuity plan? How do we make sure that patients don't receive a far worse experience if we do have an issue with our network infrastructure, or something hasn't quite gone to plan? We've got to have that kind of in the back of our minds as well. How do we make sure we've got backup systems and processes in place so that if we fully digitise our pathways end to end, that we can still function, because we know the cyber threat and there's other things out there we've got to consider. So I'd say, think about the organisational boundaries. How do we collaborate better, keep the patient experience at the centre? And we've got this ongoing challenge around balancing our investment in keeping the foundations in place and doing the new exciting things.
Fantastic. Thank you, Andy. And it's just turned to 10:59, so we are up on time, but I think we've squeezed everything we can out of this webinar. They've covered a lot of points there. It's been fantastic to hear about the work in Leicester and Northamptonshire. Thanks for joining us, Andy. And Simon, thanks for bringing the perspective of Restore and what you're doing and how you're tackling this challenge and helping organisations tackle this challenge too. So it's been a great discussion today. There will be a write-up, and the session has been recorded, so you can read or watch it back at a later date, and we'll publish the article to HTN soon. So it's 10:59. I'm conscious of time, so thanks again, Simon and Andy, for joining us. Thanks to everybody in the audience. I'll close the session here. Have a nice day, everyone, and we'll see you on the next webinar, which will actually be next year. So this is the final webinar of the year, so we've ended on a good one. So thanks, everybody. Take care. See you soon. Cheers.
Thanks all.
Thanks, John.
Thanks. Bye.